Good afternoon, everybody. At the outset, I must thank Professor Deeman and Dr. Amit Goyal for inviting me here, and thank you, chairpersons, for those kind words of introduction. We'll be covering use of DOACS in vascular disease of liver, and we'll discuss mainly about Budd-Chiari syndrome and portal vein thrombosis and non-cirrhotic portal fibrosis. So we'll start with Budd-Chiari syndrome. Traditionally, we had the stepwise therapy for Budd-Chiari syndrome, where the first step was medical treatment, which was anticoagulation. However, we realized that even if around 20% of patients who responded to anticoagulation initially do have loss of response in almost 40% on subsequent follow-up. This was a study done by Dheeraj Agrawal, wonderful study done by him. And in this study on binary logistic regression analysis, presence of ascites at baseline was associated with loss of response in the second year of medical therapy. And therefore, this impacted the Budd-Chiari appraisal guidelines, where the algorithm changed from simple stepwise to only in patients who are asymptomatic, you will treat medical therapy alone. And those who are not asymptomatic, that is those who are symptomatic, if they are amenable to hepatic vein reclination, there we should directly go to for hepatic vein reclination procedure. And only those where tips would be required, you can give a trial of medical therapy. And those who don't respond, you can go for tips. So the recommendations in the appraisal guidelines were also that not all patients are in the prothrombotic state at presentation, and therefore we need better tools for assessment of coagulation status in these patients. It remains the first line of therapy for patients with BCS, but clinical discretion is recommended in those who have a hypocoagulant status on thromboelastography. The key thing here was that the choice of anticoagulation for this initial therapy is not VKA or DOACS. It is actually low molecular heparin, and all the evidence for the initial therapy is with low molecular heparin, which may be given for a period of 2 weeks to 2 months. For the long-term anticoagulation, VKA are preferred, and routine use of DOACS cannot be recommended currently, but a weak recommendation with weak evidence. Then recently we had the Baveno 7 guidelines. I'm not going to go to details of PVT because this will be covered by Dr. Sanjeev Sehgal in the next talk. But again, coming to the choice, unfractionated heparin should not be used because of the high risk of heparin-induced thrombocytopenia. You start with low molecular heparin and then switch to vitamin K antagonists, and DOACS are considered an option in selected cases in the absence of antiphospholipid syndrome. This is important because in patients with antiphospholipid syndrome, the efficacy of DOACS is controversial and the risk of bleeding is higher. So these are the patients where we should not be using DOACS. Should be given for 6 months, and those who have a thrombotic state, it should be given long-term, and D-dimers less than 500 means that the risk of the risk of thrombosis is high, and therefore you should restart if the D-dimer is more than 500. So the 3 choices are unfractionated heparin conventionally, low molecular heparin, and vitamin K antagonists. And out of this, the guidelines have preferred vitamin K antagonists. But what are the problems with vitamin K antagonists? Monitoring of INR, we know the variability that is there, the problems that we face. We also know that the baseline INR may be deranged. So what is the new target in these patients? So these are some of the problems which are there. And in addition, a problem specific to India is the high prevalence of VKORC and CYP2C19 mutations, which may be present in up to 46% of patients with Budd-Chiari syndrome, at least in the Western Indian population. And these patients who have any of these mutations are at higher risk of having a bleed with vitamin K antagonists, despite being in the therapeutic range. So what is the current status of these DOACS and what is the US FDA label? So in the US, there are 5 of them which are available. For us, at least 3 are available, that is apixaban, dabigatran, and rivaroxaban. Out of these, the reversal agent is available for dabigatran, which is adalimumab. For the other two, they have just been approved, but they are still not available for us in India. We do not have robust data for the use of these drugs in patients with vascular diseases. The reversal agents are still not widely available. The cost is much more than VKA, and we still don't have awareness. We still have patients who are on these DOACs coming to us and saying that the INR is not in therapeutic range. But why was there a need to change? So this was a paper which was beautifully presented in the ASLD last year, which looked at the usage of anticoagulants for acute venous thromboembolism in patients with advanced liver diseases, single center retrospective study over last 10 years. And over around 900 patients, of which 216 patients received therapeutic and 37 patients received prophylactic dose. And if you look at the pattern, the red here are the DOACs, and the yellow is low molecular heparin. So if you see over the period of last 10 years, there has been a very rapid increase in the use of DOACs, and there is a almost steady level of low molecular heparin. The green is vitamin K antagonists, which have really gone down. So whether we recommend or don't recommend, the reality is that people are using increasingly DOACs and are going to use. So it is better that we get prepared and we generate data on this. So this was a paper which was presented by Aurelie and at EASL in 2021, the report study, use of rivaroxaban 15 milligrams per day in patients with past history of portal vein thrombosis for rethrombosis of the portal vein, and those patients who were on rivaroxaban, it was 0 events per 100 patient year. And the bleeding risk was the same as those who were not on any anticoagulation. So we had a long discussion on this study at the recent EASL meeting, where the question was asked, why rivaroxaban? And the answer was that was the only drug that was available to them at that time. The other DOACs were not available, and that is why rivaroxaban was chosen, because this study was planned in 2012, which eventually got published in 2021. Another study presented at ASLD 2022, comparative efficacy and safety of DOACs with vitamin K antagonists for cirrhosis patients and portal vein thrombosis, a systematic review and meta-analysis. 11 study, 4 types of DOACs. The pooled rates of PVT recanalization was 46%, PVT progression was 12.9%, major bleeding was 7.9%, and death was 10.2%. DOACs were associated with a higher pool of portal vein thrombosis recanalization and lower risk of PVT progression. The pooled risk of major bleeding and death was similar between DOACs and VKAs. This excellent study done by the AIMS group, which looked at the primary patency of endovascular stent post-intervention, comparing between VKAs and DOACs, and showed that there was slightly better patency rate with the DOACs. When they looked at the combined probability, the composite endpoint of efficacy and safety, it was initially same. If you see, it is the graph starts from 80% to 100%, so it is not a huge difference. It's a difference in few points, and the benefit usually starts beyond 15 months. This is again a study published in Liver International 2021, safety of DOACs in patients with advanced liver diseases, 133 patients total, 104 advanced chronic liver disease, and 29 vascular liver disorders. Very few patients on dabigatran, majority of the patients were on edoxaban, some patients on apixaban, very few on rivaroxaban and dabigatran. If you look at the data on bleeding, almost 10% significant bleeding risk. The resolution of PVT was poor, it was less than 10%. If you look at the discontinuation of DOACs, significantly high in advanced chronic liver disease, almost 1/3 of the patients had discontinuation, but vascular liver disease was much better, only 14%. And the bleeding was similar in both the groups, 10.6% and 10.3%. If you look at the procedure-related bleedings, it was 12.8% in ACLD, 3.4% of all the procedures, which is similar to vascular liver disease, same as 3.6%. But the important thing in this study was the vascular liver diseases were PSVD and non-cirrhotic portal vein thrombosis. There was no BCS, there was no cirrhosis with PVT. And therefore, we should not apply this data of safety and efficacy in this study by just looking at the abstract. Look at the abstract, it is grossly misleading. There was no Budd-Chiari syndrome, there was no cirrhosis with PVT in this study in the vascular liver disease group. Look at the DiMaria study. This is competing risk analysis comparing the incidence of spontaneous bleeding and spontaneous major bleeding in ACLD. And you see that both are significantly high, especially in child pug B and C, in patients who are treated with VKAs as compared to DOACS. So while direct DOACS are increasingly used in patients with liver diseases, the safety data in advanced chronic liver disease is limited. Any spontaneous bleeding occurred in 38 patients during treatment with DOAC, of which 23 were graded as major. Incidence of spontaneous bleeding in advanced chronic liver disease was higher in child pug B and C patients when compared to child pug A, but not with the presence of HCC or varices. And of course, they looked at peak edoxaban anti-TN levels because that was what was commonly used, which is not applicable to us. So if you look at the advantages and drawbacks of the available anticoagulants, VKAs versus DOACs, we have a much longer experience with VKA with limited experience with DOACs, favorable safety profile for both, but we do not have data with child pug C with DOACs, except for a few isolated small case series. With renal function, VKAs are not impacted, whereas with DOACs, you have to be very cautious in presence of renal impairment. The advantage of DOACs is it is short action, but for reversibility, we really do not have agents here available to us. And the APCC, the activated protein C concentrates, which may be needed, are expensive and not widely available. And DOACs are costlier. Plus, DOACs do have interactions with CNIs, statins, and NSBBs, which we commonly use, whereas VKAs have interaction with antimicrobials and many of the food. So if you look at the recommendation for DOAC therapy, for child pug A, no dose reduction for any DOACs. For child pug B, dabigatran and apixaban can be used with caution. Rivaroxaban is not recommended in child pug B. And child pug C, do not use any DOACs. So to summarize, my dear friend, patients with cirrhosis and child pug A and GFR more than 50, no problems in using DOACs, we can go ahead. In patients who are child pug B, GFR less than 30, we can use these drugs with caution, but avoid using, dabigatran, you have to be cautious if the GFR is less than 50. And if the patient is child pug C, then don't use any DOACs. With rivaroxaban, do not use if the patient is child pug B or C, or in patients with GFR less than 15 or on dialysis, do not use any DOACs. The DOACs appear safe and effective in NCPF and non-cirrhotic portal vein thrombosis for sure. Avoid the use of these DOACs in the presence of antiphospholipid antibody, and we should have access to reversal agents or activated protein C complexes to treat the toxicity. Thank you very much for a patient hearing.